When I was 17, I took my first introductory course to healthcare. My professor told a lecture hall of first-year students that when they worked at a major metropolitan hospital, they would look at patients' addresses in order to tailor their care towards them. When I gently suggested that tailor sounded an awful lot like stereotyping, they got visibly upset with me. I still remember the feeling of sitting there listening. I was 17 and barely knew anyone in my year. They seemed so happy, like the advice that they were giving out was so great, and it felt like I was the only one who had any issue. Medical racism has deeper roots than we realize. It can be very covert forms, and it doesn't give you the opportunity to self-advocate or much of a fighting chance. It presents as good intentions coupled with a lack of self-awareness to do its damage. Those patients would never know, because how could they? A large part of the issue is that most people do not realize it goes beyond doctors refusing to listen to the concerns of our parents or nurses that will ignore the pain of patients of color, assuming higher pain thresholds. It takes the form of students never learning symptoms on darker skin. It's the funding of research and allocation of those resources, and who gets to take part in those studies. It's entry into healthcare being gatekept by expensive standardized testing and unaffordable textbooks. It's a nepotism that goes into who these schools will ultimately select, and the privilege of having the time and ability to pad resumes not afforded to low-income students and disadvantaged. It's a complete removal of responsibility and power dynamics when discussing the historical failures of the medical community when treating patients of color, always left a small footnote as to the whys and hows, such as the forced sterilization of Indigenous women in Alberta and British Columbia. When we fail to acknowledge or educate our students on institutionalized racism and how it affects all facets of our daily life, we produce healthcare workers that are desensitized and fail to question the norms which surround us and we ascribe to. Until we can address some of these root causes, patients of color will not receive the quality of care that they deserve. Recent studies from the American Medical Journal have shown that although there are obvious improvements to the healthcare system, racial and ethnic minorities continue to receive lower quality care in comparison to white middle-class counterparts. They are also often routinely denied medical care and have higher rates of illness and death. A greater emphasis needs to be placed on discussions surrounding race and privilege. Healthcare workers need to have the best education in order to serve their patients and their concerns. They cannot adequately care for their patients in a system that was originally designed to leave patients of a certain community, color, and socioeconomic status out. The education received plays a large role in that, and when they enter the workforce and interact with patients and these issues, they can't serve them. The medical community has a long-standing history with the medical mistreatment of patients of color, and there is a very legitimate mistrust of hospitals, the medical process, and those involved that can sometimes get brushed off as hysteria or conspiracies by healthcare workers and those in the field, when that's not the case. They are valid concerns when less than 50 years ago, hospitals were using disadvantaged Black and Indigenous people as controls in medical experiments they had neither consented to or had any knowledge about. Between 1942 and 1952, the Department of Indian Affairs of Canada, under the direction and supervision of two physicians, Dr. Percy Moore, the Indian Affairs Branch Superintendent of the Medical Services, and Dr. Frederick Tisdall, a nutritionist and former president of the Canadian Pediatric Society and one of 3 pediatricians at the Hospital of Sick Children, performed nutrition experiments on Aboriginal children at 6 residential schools in Canada. Parents were not told, and consent was never obtained for these highly unethical experiments, even as children died. They were split into control and treatment groups of malnourished children and denied any adequate nutrition. In one trial, the experimental group was given supplements of riboflavin, thiamine, and ascorbic acid in order to ascertain whether this would lessen the problem of malnutrition. It unsurprisingly didn't. Children were given a mix of flour containing added thiamine, riboflavin, and bone meal. This, of course, did not improve their nutrition and led to them becoming anemic, leading to more deaths and affecting their development in irreversible ways. Doctors and research staff involved attempted to control as many factors as possible. Where some Indigenous children were allowed to access dental care, others were denied it to see the effects of gingivitis coupled with malnutrition. Government-funded child abuse is what this was, helped and furthered by medical professionals who saw these children as less than. The children who survived this or similar medical malpractices or witnessed it happening to their friends would grow up to have families of their own. These kids would grow up hearing stories from their grandparents and elders about families, people who would go to hospitals and come back even more sick, unable to conceive or sometimes even die there, who would then grow up to watch their parents' pain disregarded, explained away for their exceptional pain tolerance, and denied access to medication, and then finally experience that for themselves, completing the terrible cycle of medical mistreatment. Now, skeptics may be inclined to say, well, that was almost 70 years ago. Blatant racism and mistreatment like that isn't really a thing now. Responding to this requires breaking it down to smaller parts. 70 years ago seems like a lifetime, and it both is and isn't. The children of the adults who created these policies are still alive, as are the children who watched or heard of how their parents suffered from it. The policies created, its aftermath, is still very present, as are the healthcare workers that these systems trained. Joyce Equichon, an Indigenous woman, a wife and mother to 7 children, recorded the abuse and insults hurled at her by nurses as she lay dying in her bed. Aware of her history with heart problems, she attempted to let staff know that she was receiving too much morphine. They can be heard telling her that she is stupid as hell in between her screams of pain. This was in the fall of 2020. It now begs the question of how many of these same instances occur but are missed because no one is present to record them. Carol McFadden, a 53-year-old Indigenous woman, visited a clinic after discovering an odd-shaped lump in her breast a few years ago that was later diagnosed as a plugged milk duct. The doctor then chastised her for coming, telling her that she should have done self-screening and a mammography on her own. Flash forward to this fall, and this same lump is now diagnosed as stage 4 breast cancer. Although she is currently undergoing chemotherapy, it's already metastasized to her liver. The median survival rate of cancer with this sort of spread is 3 years. Discrimination like this is so rampant and obvious to the communities it affects, it leads to awareness, and awareness leads to reluctance to seek out help. With so many diseases and ailments dependent on the time and stage that they're caught at, really listening to a patient's concerns can be the difference between life and death, and whether or not it's missed or caught too late. Patients having to coach themselves into getting small problems sorted out, because is it even worth the disregard and contempt that they may experience? These are not questions that anyone should have to consider, much less our most vulnerable. Using a 4-step approach, the healthcare system could be redesigned. The first step would involve increasing awareness and educating healthcare workers and allied staff about the communities that they serve and how to meet and address their unique and individual concerns. This would also involve monitoring the progress being made towards eliminating any existing gaps and identifying all the sources of racial and ethnic disparities. Cultural education training for future and current healthcare professionals would be emphasized, ensuring that they are equipped to better provide quality care starts with the proper education. A more complex and detailed education and courses for entering healthcare workers on approaching bias and prejudice. When discussing the historical failures in the medical community, ensuring that they understand that even if these events were before their time and they played no part, they must work to bridge the gap and distrust that is created between these communities. Every one of them is responsible for ensuring an end to the cycle in their every patient interaction. The second step would be re-examining any existing policies and legislation, strengthening them when possible, and creating new regulation practices wherever needed. This, coupled with healthcare workers, providers' new perspectives, would strengthen the relationships that exist between patients and their providers, and help start the process in rebuilding the trust between the medical community and those that are being served. This step would also involve ensuring that healthcare teams are diverse and minorities are not just represented, but also in the forefront leading. This step also involves making entering healthcare more accessible and working to end the gatekeeping that is entering the medical field. The third step would involve enhancing communication between communities and their healthcare providers, and really work on rebuilding trust between vulnerable communities and the medical system. This would include employing more interpreters for different departments, social workers that are community-based and understand and are familiar with the issues, and it would also promote more transparency to the medical process, stressing the importance of asking questions when you don't know and trusting your patients and that they know their experience best is a large part of that. People don't know or assume that they come from a place of understanding naturally, but that's not the case. A large part of healthcare is meeting patients where they are at and addressing their specific and unique concerns, and that's not possible if you aren't knowledgeable about it. The last step focuses on making patients more aware of their rights and how to better access good care when they encounter providers who are attempting to withhold it. It would also include collecting data and reporting on healthcare access and how it intersects with a patient's race, ethnicity, socioeconomic status, and their ability to speak English. This way, progress could be properly followed and the places that professionals fall short on could be addressed. Arguably, one of the most dangerous forms of prejudice is the silent kind, the one that takes root in people who are unaware and who don't truly see the error of their ways. They won't attempt to further educate themselves because why would they need to? They aren't racist, they are simply doing their best. This is why it's so important to address the root of these issues, the silent parts, and only then can we really guarantee quality care for all Canadians.